Hey, everybody. Welcome back to Poem Peeps. We are doing another one of our episodes on Rapid Fire Journal Club. We're reviewing some of the high impact articles in pulmonary and critical care medicine, focusing on some pulmonary articles right now and going through them and how they've impacted our care. I'm joined today by Matt Sy. Matt is an internal medicine resident at Beth Israel Deaconess Medical Center. We've been fortunate enough to work together, and he helped us go through this article and prepare this. Matt, welcome to the show.
Thanks, Dave, for having me. It's been a delight.
Yeah, absolutely. So we are talking today about the reduced trial that was published in JAMA in 2013. Matt, you went through this, so I'm going to hand it over a bit. Can you tell us a little bit about the background leading up to this trial and then what the trial was looking at?
Yeah, and this trial was so fundamental, Dave, because it occurred during a phase of sort of evidence-free period when people were trying to treat COPD exacerbations. And at that time, what we knew was that there were benefits to systemic steroids, but no one really knew, how much steroids to give or how long you were going to continue steroids. And we all know by now that there are a lot of unwanted side effects for prolonged steroid use. And so this trial was designed really to help us answer that.
Yeah, I totally love that. I feel like this is one of these trials that we don't talk about that much, but the outcomes from this have just become the everyday practice that we teach in the hospital to new interns, to medical students. And so it's great to know where the data comes from. So, what was the design of this trial? What were they looking at?
Yeah, so this trial was a multi-center, double-blind, and non-inferiority, a randomized control trial that took place in Switzerland. And they enrolled 314 patients with COPD exacerbations, all of whom were above the age of 40 and had 20 plus pack years in their smoking history. Now, the caveat to this that we should recognize is that the way they defined COPD exacerbation was having at least two of the following: either a change in your baseline dyspnea, a change in your cough, or change in sputum quantity or purulence. And they power this as a non-inferiority trial, like we talked about, with the primary outcome looking at COPD exacerbation rate within 180 days after treatment.
That's great. And I think anytime we're looking at a trial, and part of this journal club is to be able to analyze trials, you have to look at the design to help you interpret what's going to happen. It's great. It's multi-center, it's randomized, it's double blind. It's in Switzerland. So we always have to think, is this going to be the same patient population? And we take the generalizability, but it's great that it's at multiple centers. And you're right. You're looking at the inclusion criteria, includes some younger patients, includes 20 post-back years, not even all that much for someone with COPD. And that's a very clinical definition of exacerbation, which I actually really like. It's not like they had to have a chest x-ray, they had to go to the ED. This is just two of these categories that bring in there. So it's going to be a wide scoping range. So within that, what intervention do they do for these people?
So they broke it up into two arms, and all patients received a single dose, about 40 milligrams IV methylpred on day one. From there on out, they randomized patients to either 5 days of prednisone 40 milligrams daily for total 5 days, and then and then following that placebo, or a total of 14 days, finishing it with prednisone 40 milligrams daily.
That's great. And what did they find? What were the outcomes?
So they found that the shorter duration of steroids was non-inferior and actually possibly reduced the rate of recurrent COPD exacerbations over a 6-month period. So the specific numbers is about 35.9% rate of COPD exacerbation in the 5-day group compared to 36.8% in the 14-day group, done by intention to treat analysis. And then from a kind of a safety standpoint, they found that there wasn't really any difference in mortality or FEV1 improvement or symptom burden.
That's great. And as you said, that what we can tell from these results is that it's non-inferior. It's a statistically important point that non-inferiority trials are not powered to show superiority of the treatment arm. So all we can say is non-inferior, but it's really nice that, as you pointed out, the trend is towards benefit in the lower end group. Not only do we see non-inferiority, maybe a trend in that way. And then another important thing, like you notice, no difference in mortality, FEV1, or symptom burden. And so you could tell patients that you're going to feel the same if you get 5 days versus 14 days of steroids, and you're going to have the same rate of exacerbations just with fewer medicines that's going through. Any takeaways that we bring from this trial?
This was enlightening to me because I feel like throughout all my training, we had been using 5 days of prednisone. That's just what I was taught. And then realized that people previously had done as long as 14 days. So the biggest takeaway for me is that we know that's the shorter duration of steroids, maybe less is more here. And that trial probably was the impetus for what is currently the standard of care for COPD exacerbation.
Yeah, I absolutely agree. It seems like one of those trials that just sits in the background now, guiding what everybody is taught. But we should always say with any trial, we always have to take and think about it. We've all practiced medicine, listened to our training to practice medicine, and we know that there are judgment calls to be made, and not every patient is the same. Not every patient fits in the trial. So, are there any things that we should consider, some limitations or special notes about these trial findings that we need to keep in the back of our head when we're treating a patient with COPD exacerbation who comes in?
Totally, and I think like you pointed out, Dave, the understanding the design and the patient population of the trial is so critical here. So the specific limitations for this trial, like I said, it involved primarily younger people with COPD exacerbations. They did exclude people who had concurrent asthma, which we occasionally see. And they also excluded people who were end-stage COPD, so people with a predicted survival of less than 6 months. And then for those of them who received chest imaging, they did also exclude any evidence of pneumonia on imaging. So people with a concurrent picture might not really apply to this.
Absolutely. And those are great considerations. I'm going to add a couple more that I take from this trial, which is interesting, is that not only do they exclude patients who had clear pneumonia, but they also treated all the patients with 7 days of antibiotics, and which is pretty interesting. That I think is reflecting the time where for COPD exacerbation, you always got 7 days of antibiotics. I think we think a little bit more about that now, but so we have to take that into consideration that not all our patients are getting that. And then you said very eloquently that we're excluding people with end stage COPD. Interestingly, they didn't aim to do this, but if you look at the study population, very few patients had minor COPD or gold A or minor obstruction in the study. And so we just have to keep in mind that these findings may not apply to people on the extremes of their COPD diagnosis. This is really for people who are in the moderate to severe COPD, but not quite at the end stage. Great, Matt. This was wonderful. I think this is great takeaways. We're going to be releasing an infographic that you helped prepare or essentially did prepare, which is awesome. And I hope everyone can tuck away to look at a reference. And I hope you'll come back and join us for another article soon.
This has been a blast, Dave. Thanks for having me.
Yeah, absolutely.